Yeah, we'll move on to the first slide if that's okay, please, Jeff. Thank you. So welcome everybody to this second in a series of webinars where we're showcasing pathways developed by the Centre for Sustainable Delivery in collaboration with clinical communities, and to provide a forum for education, informal discussion and question and answers. My name is Stuart Sutton. I'll be chairing today. I'm a clinical director and GP in Renfrewshire, and have a role with the RCGP working on primary secondary care interface with the Centre for Sustainable Delivery. We are fortunate to have two fantastic talks today. We've got coverage of the National Headache Pathway, and that'll be with Dr. Callum Duncan, who's a consultant neurologist in NHS Grampian and the workstream lead for headache in the Neurology Specialty Delivery Group at the CFSD, as well as Anne Wales, who'll be talking about RDS, the Right Decisions Service platform, who'll be joining us from HIS. There's a little bit of housekeeping on the next slide, just to make you aware. The webinar will be recorded and it'll be available after this live event on the CFSD website. And there'll be an opportunity for questions and answers to our speakers. You can see there is a Q&A button at the top there, which is highlighted on the slide. That'll probably be the best place to post questions during the session. And at the Q&A session, if you'd like to ask a question, you can put the raise hand function up and Jeff will kindly unmute you and bring you into the conversation. So I think without any other further ado, I'll hand over, if that's okay, to Dr. Callum Duncan for our first talk. Thank you very much.
Thank you very much. Thank you for inviting me to talk about the National Headache Pathway. So I'm a neurologist with a headache interest in NHS Grampian and work quite closely with my headache colleagues across Scotland. So this was a collaborative effort of the headache neurologists and a number of other people. So why do we need a headache pathway? Well, you all know that headache is extremely common. 1 year prevalence of headache disorders of any description is 50% prevalence. So most people have headache. In general practice, 4.4 consultations per 100 registered patients and make up 20 to 25% of neurology referrals and appointments. And that 25% makes up a small proportion of the headache that's seen in primary care. So it is a large group of patients. And the idea is to make management of what is usually migraine more straightforward. So 94% of what people in primary care see in headache is migraine, and only a very small proportion have secondary headache, and a small proportion have other things. The most common headache, episodic tension type headache, is not really going to present to doctors. It's usually managed by patients. And the global burden of disease ranks headache disorders second in years lived with disability. So it is a common disabling condition. The landmark study was a very interesting piece of work. So this is GP practices across Europe, across the States, and a GP diagnosis was validated with a standard diary diagnosis of migraine. And 94% of people attending primary care had migraine. And if the GP thought the diagnosis was correct, they were right most of the time. If the GP thought the diagnosis was incorrect, it wasn't migraine, it was something else, they were wrong most of the time. The most common misdiagnosis were tension type headache, which is probably milder migraine, and sinus headache, which generally is migraine. Migraine is the third most common condition in the world. It outranks diabetes, asthma, and epilepsy combined, and 1 in 4 adults will have migraine in their productive years. It causes a lot of cost, so both direct and indirect costs, and work days lost with presenteeism and absenteeism. So it is a significant problem, and if we can manage it better, we can manage things better, and hopefully that can be done sooner in the patient journey, so primary care rather than in secondary care, and that's the idea behind the pathway. So I was group lead, and we undertook the pathway in sections. The idea really was to pull together guidance in a structured format that's usable, to focus unashamedly on migraine, medication overuse, and the things that worry us all, red and amber flags, to include other primary headaches like cluster headache, and encompass sort of making confidence in diagnosis and in management. We use existing guidance. I'm also chair of the SIGN 155 guideline, which was helpfully updated around the time this pathway is being developed and is currently being updated to include new treatments. We also included the British Association Study of Headache guidance, NICE guidance, and Scottish Medicine Consortium guidance, and the group updated evidence that wasn't current. The Scottish Headache Interest Group, which is a headache neurologist around Scotland, provided a very useful sounding board and grounding board for the pathway. And for the pregnancy information, we did this in tandem with the Obstetric Neurology Working Group, who produced this National Maternity Network guidance, and the two documents align very closely. And the information in them is the same, with some extra stuff being in the obstetric guideline. So the target audience is primary care, and that includes anybody who will see. So it should be useful for advanced nurse practitioners as well as general practitioners, and useful for pharmacy. In Grampian, we've been doing a pharmacy first project, teaching community pharmacists to manage migraine, particularly acute treatment, as they may be the first people that patients come in contact with. So we've been doing that, and we've been rolling it out across Scotland. So community pharmacy important, general practice, and the guideline cuts across all of the sections of healthcare, including general neurology. So it's hopefully useful for all comers. So management and referral. Of course, we want to ensure there are no red or amber flags present that might want to think about a secondary cause. This is going to be a small group of patients, and there's guidance on how to manage that and who to refer in. The bulk of the guideline is unashamedly on management of migraine, and we should be able, with good diagnosis, to then be able to give acute treatment and prevent treatment with the main initial options correctly, and the guidance is designed to try and help with that, so that when people come into a headache service, they've been through the standard options first, and we can go on to more advanced treatment, or we're seeing the more complex group of patients. It's also aimed to facilitate active triage. So if we're referring back with advice, there is the National Headache Pathway to help supplement that advice and for use. Medication overuse headache remains a significant problem, and there's guidance on how to manage that. Cluster headache is really a secondary care management, but it's important to recognise in primary care, and there's detail on cluster headache, and there's detail on open access CT. So if you've got somebody who you think has a primary headache disorder, but you're not quite sure, they've got no red flags, and you want reassurance for yourself or the patient, then there is open access CT, and this is underutilized. So this is on the Right Decisions app. Anne Wells is going to talk to you about the Right Decisions service, but this is open access, readily available in a format that you can get on a smartphone, on a tablet, on your office computer, on a laptop, and the screen customizes to the device you're using. So it's a really quite a usable app. The pathway is available on the CFSD website, but also on the Right Decisions website in the neurology page. And this is what you're going to see when you come into it. So there's also the FND pathway there now. So you click on the headache pathway, and then you see the various sections, and it's purposely split into sections to make it easy to use. So the standard information is in the National Headache Pathway section. Then there's detailed advice on acute and preventative treatment, on open access imaging CT, on pregnancy, detailed information on pregnancy, on menstrual changes and menopause, on medication overuse, and then on indomethacin and on cluster headache. And this is designed to be kept up to date. There'll be a review every 18 months, and if new things come on, and we'll be reviewing it up soon because of the changes in topiramate. So it should be current. Diagnosis of secondary and the headache. So we've got red flags, amber flags, green flags here. We've got a table on differentiating tension type headache, cluster headache, and migraine. And we've got some information on useful things that help the diagnosis. And migraine really is the most likely diagnosis for any patient presenting to primary care with headache. So having a way of confident diagnosing that is going to help. Many of these patients can be successfully managed in primary care, and the idea behind the pathway is to facilitate that and provide a resource. If it's a clear diagnosis, then we can undertake treatment more effectively, and hopefully then patients coming into secondary care have already had the initial treatment options, and those who've been successful with initial treatment options are treated earlier and more effectively and don't have to come to secondary care. So red flags suggest the need for an urgent assessment to include a secondary cause, and that would normally be on the same day or within a week or so, rather than an urgent appointment. Amber flags may indicate secondary cause, may still be migraine, and you might consider referral. Green flags are there to give us confidence that it's a primary headache disorder, and the main green flags are someone with recurrent episodic headache. So a headache that comes, goes away, comes, goes away, comes, goes away, and almost nothing else does that apart from migraine, and then a long history of headache or daily headache. The longer the history, the less likely there is to be a concerning cause. These are very standard now as red flags. So the key ones are if the headache comes on instantaneously, is severe, and lasts for a reasonable length of time, then you need to consider subarachnoid hemorrhage and its differential, and that patient goes straight to accident and emergency, even if you found them a week later. And getting them in early will ensure, if it's possible, a CT scan is done within 6 hours, and you can make a positive diagnosis. New focal deficit. So focal deficit would be like a weakness down one side. So headache with new neurological symptom, and this is a helpful, brain tumor, but any focal headache will do this. So new headache with a sort of a progressive focal neurological, so progressive weakness or progressive personality change, new headache plus seizures, new headache plus cognitive change. So that's how brain tumors or focal cause headache. So new persistent headache plus, and that tends to evolve over days or weeks or a few months. If someone's had just headache for 3 months or more, it is much, much, much less likely to be a secondary cause, and you can treat them for primary headache. Ensure they don't have giant cell arteritis, meningitis, look for systemic features. If someone's over 50, you need to have a bit of a stronger think about it, but most patients over 50 are going to have a primary headache disorder, but you just need to be a bit more vigilant because a new headache over 50 can have a secondary cause. Amber flags, so headache that's worse upright makes you think about low pressure. Headache that's worse lying flat makes you think about high pressure. If it's low pressure, they're going to do an MRI scan and then an urgent referral into neurology rather than an open access CT. If your headache's triggered by Valsalva, that might indicate an underlying cause. Exacerbated is usually exacerbation of migraine, prolonged aura. progressive headache, head trauma is clearly obvious, past history of cancer is obvious, and clearly if the patient comes back again and again with things worsening, you pay attention to those. If they're green flags, there's episodic history, long history, that's very reassuring, and those patients are likely to have migraine. Open access for CT. This is really for a patient you don't think is a secondary cause and you want reassurance for yourself or for the patient. So if you've got a red flag, they need to be referred in appropriately for that. You need to think about whether CT is the right thing or not. If someone's got quadrilateral arteritis, you're doing blood tests, you're not doing a CT. And you need to think about incidental findings. So incidental findings are more common in MRI than they are in CT, but white matter change is extremely common. And you can see the white bars in this second graph indicate white matter changes which increase exponentially as one gets older. So these are very, very common, and you need to explain that to patients that we're going to find this, and then have a way of dealing with incidental findings if you're organizing CT. If you find a benign tumor, you need then to refer it into the neurosurgical service, for example. Patients need to know that. The number needed to scan to get an incidental finding for MRI is 37. And reassurance doesn't work long term. This is quite a neat study looking at people who had chronic migraine who were given an MRI and to see whether it changed their anxiety levels. It did so for 3 months. It didn't do so at a year, but patients used resources less. So reassurance is a short-lived thing for people with headache. And so you need to use your scans judiciously. Migraine. So essentially migraine is a straightforward diagnosis, to be honest. So it's a moderately disabling headache, moderate to severe disabling headache. It's generally long, it builds up gradually. It lasts for hours to days, typically 4 to 72 hours untreated. If you treat it successfully, it lasts much less than that. There's nausea, sometimes vomiting. Patients are intolerant to noise, light, smells, touch, and movement. Often patients will underplay it and you need to ask them specifically the questions because they will often not volunteer things. If the head is sore on the same side as the headache, that's allodynia. That's very common in migraine. And it's usually worsened by routine physical activity. And that can be anything from a slightly obtunding headache where you're just not feeling right, through to being lying in bed, nauseated and unable to do stuff. And if you're getting that repeatedly, then that is migraine. That's a very, very typical history. And you can usually be confident that that is the diagnosis. There's an ID migraine screening tool. So if you feel sick to your stomach, if your headache limits you, and if lights bother you during a headache, then that's a high predictive value that that is migraine. It's a nice, simple tool that we can use. We split things into episodic and chronic. So episodic is 15 days or less in a month, and chronic is 15 or more. In people with migraine who have chronic headache, they tend to have background milder headache with superimposed migraine attacks. And the definition is 15 or more days of headache per month for 3 months, of which 8 should be migraines. That's a very typical pattern. And asking somebody if they've got more than one type of headache and explaining both is a good way to bring that out. So the diagnosis of migraine can be relatively straightforward. The migraine brain is a sensitive brain. It doesn't like change. Triggers are stress, hunger, sleep disturbance, dehydration, environmental stimuli, and in women, the second commonest cause is the menstrual cycle with a drop in estrogen before menstruation. Diet is usually a small trigger, and it changes the threshold, makes it easier to have your migraine headache. And this just shows how important triggers are for some people. So this is a lady who had intractable, very difficult to treat migraine, who's having 5 or 6 severe migraines per week, changes job, completely different, and within 2 months she's having 1 moderate migraine every 2nd or 3rd week. It's a massive change. So it just shows you how important triggers are, and people with migraine need to have a routine generally, regular meals, regular sleep, regular everything. The two main sections are the acute treatment and the preventative treatment, and they're split into different sections. So mild to moderate attacks, moderate to severe, inflammation and triptans, detailed use. Triptans are often underused, and this should hopefully give confidence for their use. And then the new treatment, rimegepant, which is a CGRP antagonist, and then both primary care and secondary care preventative options. So if you have a migraine and you're treating it acutely, you want to treat the patient early in the headache. So when the headache is building up, so good evidence for that. Start with something straightforward, aspirin or non-steroidal. You can step up or stratify to a triptan. I've talked about stratifying treatment. The response to triptans is idiosyncratic, so if one doesn't work, you use a different one. Adding treatment to triptans is helpful. So adding an antiemetic, adding a non-steroidal adds benefit and is useful for managing more severe headaches. And we've now got rimegepant to use in people where triptans are contraindicated or where triptans are not useful. Important to think about the route. If someone vomits within half an hour, tablets are not helpful. And you normally start with single treatment, non-steroidal aspirin for a mild headache, mild or moderate headache, triptan for more severe. If that's not working, combining is really important. So triptan and non-steroidal, triptan and paracetamol, or combination of those with an antiemetic. When to take treatment, do it early. There is good evidence that that works better. If you wait until it's significant, it is not going to work effectively. And the number needed to treat is quite different between treatments. So if you see subcutaneous sumatriptan, so 2 people to get a good successful response, aspirin 8, paracetamol 12, antiemetics on their own 17, sumatriptan 100 is better than sumatriptan 50. So 900 milligrams aspirin, 400 to 600 milligrams ibuprofen, good evidence for that. Add antiemetics, triptans for moderate to severe episodes, and then add treatments on, so metoclopramide, non-steroidals give added benefit. And this aligns with the SIGN 155. Important to ensure you're restricting acute treatment so that you're not getting medication overuse from the beginning. Don't use opioids. And this is stratification. So slow onset mild headache gets a non-steroidal or aspirin. A moderately severe, faster onset headache gets a triptan. A very severe headache gets combination treatment. And you can use the right treatment for the right person, depending on the severity of their headache and depending on their previous response. So choosing things, and the pathway gives you advice on that. Aspirin, ibuprofen, sumatriptan, first line. Side effects, almatriptan, firotriptan, naratriptan better tolerated. Early vomiting, think about the route. Orodispersible are not absorbed in the mouth, they're absorbed in the stomach, so they're just easier to take. Inadequate response, add antiemetic. It has pain relieving properties as well. Add non-steroidal. Severe headaches. There's good evidence actually that elatriptan and rizatriptan are more effective. So elatriptan is the most effective triptan we have and is still significantly better than newer treatments. So the CGRP antagonists are not better treatments than triptans. So we should still be using our triptans as effectively as possible. Where do gepants fit in? So these are the CGRP antagonists. I will talk about them in preventative treatment. But the European Federation says that if you fail at least 2 triptans, it's refractory. And if 3 of it's refractory, if it's 2, it's resistant. And 80% of people will still respond to triptans. So if you do acute treatment properly, and the pathway is designed to do that, then you probably don't need new treatments in most people. Some people will have cardiovascular risk, which contraindicate triptans, and the gepants are felt to be safe. For that, we're still waiting on more data coming in about cardiovascular safety, but at the moment we're considering them safe. They're not going to have issues with medication overuse headache, as they use with preventative treatments. And we would consider rimegepant if you've adequately treated migraine with at least 2 triptans, and there's evidence that then those people may benefit from rimegepant. So we can use that in that circumstance, or if triptans are contraindicated. So it's adequate treatment of 2 separate triptans done properly, and then you can consider rimegepant. It is quite a straightforward, easy treatment to use. We'll talk about blood pressure a little bit later. There's a whole section on pregnancy, and you can see that a lot of treatments are not helpful, but ibuprofen can be used in the first 2 trimesters, not in the third. And sumatriptan, there's good evidence that it's safe in pregnancy, so we can still use sumatriptan. We don't have evidence for the other triptans to decide. So there's straightforward evidence on that. Remember about medication overuse headache. The best way of managing it is to educate people from the beginning so that you're not developing medication overuse headache from the start. And that was one of the big drivers for the pharmacy project. So when people are getting initial advice, they're getting initial correct treatment. 15 or more days of analgesics per month or 10 or more days of triptans are enough to do it. We should not be using opioids or combination analgesics. It is likely this is not relevant for gepants, which work as preventative treatment as well. The best evidence for management is prevention, and then withdrawal of the acute treatment, and adding in a preventative treatment at the same time. But there is evidence for withdrawal only, withdrawal and preventative treatment, and preventative treatment alone. But there's a whole section on medication overuse headache. Who are we going to give preventative treatment to? At least 1 migraine a week normally, but if your migraine is well treated with a simple analgesic, then you may not want to have a preventative treatment. If you've got difficult to treat migraine and the people have prolonged severe attacks, you may give preventative treatment at a lower level. What are we trying to achieve? It's important to give people realistic expectations. So a 50% improvement in episodic migraine, 30% or more improvement is meaningful for chronic migraine. We're going to start low, we're going to build it up, we're going to give it for at least a few months an adequate dose. If it's successful, we're going to carry it on for at least 6 months to a year before trying to phase it out. If it's not successful, we're going to wean it quickly and try the new treatment. If it's partly helpful, some people might add a preventative treatment on. After 3 failed trials, we would suggest referral in to a headache or a neurology service. Of course, this is changing now because topiramate is becoming a more problematic treatment to use, and I'm going to talk about that. Sodium valproate is something we haven't used for a while and really can only use in someone over the age of 55. And so our core treatments now are propranolol, amitriptyline, and candesartan. And really, we should all be au fait and happy to use those to adequate doses. Rimegepant and atogepant as preventative treatment, certainly in the west of Scotland, are now being prescribed by general practitioners. In Grampian, we're still recommending in secondary care, but as things move, we may be more allowing you to prescribe these treatments from primary care to manage things well. Just to emphasize, the older treatments need to be built up gradually. The commonest reason they don't work is a small dose for a short time. So it needs to be an adequate dose, and it needs to be for at least 2 to 3 months at that adequate dose. And then if it's successful, carry on for a year and then gradually phase out to see if it's still required. You need to think about pregnancy planning. You need to ensure medication overuse headache is assessed and managed and thought about. Candesartan use up to 16 milligrams, propranolol up to 80 milligrams twice a day target dose, amitriptyline up to 50 milligrams, but potentially higher than that. And nortriptyline is less sedating than amitriptyline. So these are our standard treatments. And ideally, people get these tried early and properly prior to assessment in secondary care. Often candesartan would be a good starting point because it's got a very good side effect profile. But these are all first-line treatments. The best evidence is for propranolol. There is a current randomized controlled trial awaiting publication on episodic migraine, so may give us much better evidence on that. Topiramate is difficult. So it is a useful treatment. It's a Marmite drug, so it's got a high incidence of side effects, and some people find it really quite challenging. You need to ensure people don't have a history of glaucoma or kidney stones, as these can be exacerbated by topiramate. It has the best evidence of the older treatments, but it was trialed later, so that's why the evidence is better. But now the evidence is that the risk in pregnancy is the same as for sodium valproate. So there's a high risk of congenital malformations. There's a high risk of intellectual disability, autistic spectrum disorder, and ADHD. And so we're now, from June this year, needing to do risk acknowledgement forms and assess these people. And this is going to be the role of both doctors in primary care and doctors in secondary care in order to ensure women on topiramate are on it appropriately and have been adequately counselled, because they need to go on to a pregnancy prevention program and have risks discussed with them. We're certainly in negotiation locally about how best to do that. I suspect my colleagues around the country are the same. Flunarizine and sodium valproate. Really, sodium valproate is not a good treatment, so it's really restricted to 55 or over because of the issues with both men and women. I almost never use it. Flunarizine is a really helpful treatment prescribed from secondary care, and there is information on that in the pathway. So we would use it preferentially for vestibular migraine. Again, there's information on preventative treatment. And as you see, low-dose amitriptyline propranolol really only where the evidence lie. Thankfully, most women get better in pregnancy, particularly after the first trimester. So it's not usually an issue, but preventive treatment can be quite challenging in pregnant ladies who have significant migraine. And greater occipital nerve blocks, which are provided by headache services, can be a useful treatment in this group of patients. If we think about our more advanced treatments, so again, we need to think about episodic migraine, so 14 migraine days or less, and chronic migraine, 15 days of headache with 8 days of migraine or more. And the reason for splitting them up is different treatments are used in different frequencies of migraine. So the advanced treatments are the Botox and the CGRP treatments. So botulinum toxin is very well established now. We've got the monoclonal antibodies, which are subcutaneous injections once a month or an infusion once every 3 months. And now we've got 2 oral treatments. The effectiveness of these treatments is actually broadly comparable. Botox services are becoming a bit saturated, and so we're going to be moving on to discussing with patients which treatment suits that patient best. And this is an evolving field we are in with the headache services, but they are really quite useful treatments now. So ideally, people have tried the initial treatments first, and then we can get on with this in secondary care. And potentially, you guys in primary care are going to be using the CGRP antagonists as a more further on treatment. Botox is very well established now. It's a very straightforward treatment to give, but it does require treatment in secondary care. There is the PREEMPT protocol, which gives injections around the areas where the trigeminal cervical complex is, and it has pain properties. It works on TRPV, and you can see the effect. There's a high placebo rate, but it is quite an effective treatment. It is likely to turn out to be safe in pregnancy. The evidence so far is that it is, but there's not enough evidence to be definite about this. So we are likely to be using Botox more in pregnancy. Some of us are already doing that, appropriately counseling people. CGRP is a key part of the migraine pathway. So triptans block custom-related peptide release. the erinumab and the CGRP antagonist, atogepant and rimegepant, block the receptor, and the others block the molecule in the junction. So CGRP is an important part of migraine. It's a vasodilator, and one of the things we're seeing with it in some people is hypertension. So we're being mindful of that, particularly with erinumab. The effectiveness of them seems to be broadly similar. Fremanezumab is probably the better of them, and again, they're broadly similar to Botox. They get a 3-month trial, and if it's effective, they carry on for a year and then review thereafter. Monoclonal antibodies staying in the headache services. The gepants perhaps being managed more in primary care, but this is evolving. We need to keep an eye on blood pressure. We're seeing some people early on develop high blood pressure, and so blood pressure monitoring is important in this group of patients. It needs a 5-month washout if considering a pregnancy, so patients need to be aware of that. And we're currently cautious with cardiovascular risk factors because of the long half-life and the uncertainty about cardiovascular risk. Atogepant and rimegepant are treatments that are potentially able to be used in both primary and in secondary care. Rimegepant can be given as acute treatment, and it also can be given as a preventative treatment. It's given alternate days in a preventative treatment, and this is the effect of rimegepant over time on someone given it alternate days with the ability to add another treatment when treatment is needed. Atogepant is given once at night. It can cause sedation, and CGRP release is highest at night, so it makes sense to give it at night to avoid that sedation and to optimize treatment. There are some restrictions, relatively minimal restrictions. It's very well tolerated, a bit of nausea, perhaps a bit of constipation, and we're going to need to be mindful of the question about blood pressure. But it's generally a very easy, well-tolerated treatment that seems to be really very effective. So it's a good new addition, and I think we're going to be using it more in primary care, and that will evolve over time. So for episodic migraine, we're using our first 3 standard treatments. We should be using those in primary care. Same for chronic migraine. We're probably going to be using the gepants early, and then moving on to Botox and the monoclonal antibodies. Botox is only licensed for chronic migraine, and rimegepant is only licensed for episodic migraine, so it is not licensed for chronic migraine because the trials didn't look closely enough at chronic migraine. And we're going to be giving patients options, I think, rather than ensuring they go from one to the next. But if one treatment doesn't work, it is useful to consider a different treatment, and there is evidence that works. I won't belabor menstrual migraine, but in the menstrual period, some women have quite significant migraine, and you can use specific treatments to bridge that for people who have migraine predominantly around the menstrual period. There's also information on contraception, HRT, and so there's that detailed section in the pathway, so that's useful. Migraine tends to start in women and girls around puberty when the hormone fluxes are changing. Still prevalent when the hormones are more stable, and then it's worse around the perimenopause when the hormones are changing again. So there are some specific things you can do around people who have more significant headache, menstrual migraine. That's detailed in the pathway. Cluster headache, this is mostly secondary care, but I think it is useful to have the resource so you know how to manage it. Cluster headache is different once you've listened to the patient. So it's a strictly unilateral, very severe, excruciating headache with restlessness, prominent autonomic symptoms, occurs several times per day, and occurs in cluster bouts, which is very different from migraine, which evolves over minutes and hours and lasts a longer time and occurs episodically. So they're relatively straightforward to differentiate when you know to talk to them. There's no point giving oral medication because it just doesn't work. So it needs to be subcutaneous sumatriptan or nasal sumatriptan. and the preventative treatment is high-dose verapamil. Our standard protocols are in the pathway, so they're readily available. And the final thing we've added in, which is really is a niche headache treatment, but indomethacin is a specialized treatment for a specific set of headache disorders, primarily paroxysmal micrania and hemicrania continua. It works quickly if it's going to work. It works very effectively if it's going to work, but we need to do it properly. And so the reason for having it in the guideline is so that it is available when we're seeing patients with indomethacin sensitive headaches, so that there is readily available information to help with its management. So hopefully this is a easily accessible resource that's useful. It's designed to be a headache recipe book. So guidelines say yes or no. This gives you information how to do things and what next step to take and how to do it. Gives advice on red and amber flags and access to CT. Unashamedly is primarily in the management of migraine, which is most of what we see. There is a similar pathway in development, which is going to have a similar structure. So the National Facial Pain Pathway, which will contain information in trigeminal neuralgia, Sungton Suna, temporomandibular joint pain, etc. And hopefully will be a useful resource as well. And we're hoping to have that through processes in 2025. Thank you, and I'm happy to take questions.
Brilliant. Thanks so much, Callum. That was fantastic. I can see we've already got a few questions in the Q&A section there. So if you have got any more questions, do add those with the Q&A button, or feel free to put your hand up if you'd like to ask a question. I thought that was really helpful. I think a couple of my reflections, Callum, I thought the realistic medicine slant around scanning was really useful for GPs, because I think we do often see people who we feel now apparently potentially wrongly maybe reassured by having a scan or having a therapeutic scan, and that kind of number needed to scan of 37 to find an incidental finding was really interesting. I think also the idiosyncratic response to triptans is something that I suspect maybe, certainly for me, you maybe don't think enough about continuing to try second or third triptans. So that was also really useful. And I think the point around topiramate is really relevant to primary care at the moment, because it may be that we have patients in our practice who we started on, or our colleagues or preceding GPs before us started on topiramate in primary care without any secondary care contact, as it was kind of part of that preventative toolkit, who may not be on the pregnancy prevention program. So it might be a good option for audit, I think, in primary care for those of us who might be considering looking at that and trying to find those patients. So few reflections from me. I thought it was fantastic. Thank you. I'm going to go straight across to the Q&A box, if that's okay. I don't know if you can see those as well. Callum, the first one we've got is a question from Liam Mack Lua Hodge. Do we know why open access to CT is underutilized, and is there any available data that shows it being underutilized across or in parts of Scotland? That's good.
Yeah, I think my impression is it's underutilized. Certainly in Grampian, there was a huge worry that we were going to be swamped by requests. I suppose my view is that people are underconfident in managing headache, and there's the concern about a secondary cause. And so there's a tendency to refer in rather than using open access CT. I don't think that's necessarily incorrect. Certainly if you're thinking about what's going to be most useful for imaging for headache, actually it's MRI, it's not CT. You know, you're not having availability to that. So it really is primarily to help you manage that patient you think has primary headache, but you're not quite sure, and they want some reassurance. But I think my colleagues across just have the impression that it is not fully utilised. I don't think there's been some information from Glasgow, I think, but I don't think there's been anywhere else.
Thanks, Callum. I think the second question is linked in two parts there from Bernard Conway. We've got, do we have any comparisons of positive findings, the rate of positive findings from GPs versus other requesters? So I guess is the, do you find that there's more negative scans undertaken from GP or others?
I I don't think we have specific evidence on that, but I have audited my practice. Yeah, this was when I was doing more CTs and I was doing more headache. Of 6 months, I probably had about 30 scans, and I had 2 significant incidentals and 2 relevant findings. So the vast majority of patients had normal imaging or incidental, and that didn't include the ones with the cerebrovascular disease, which was probably about quarter to a third of patients. So it's a massive under pickup of findings in headache, which most of it is going to be primary headache.
And I think probably from a primary care perspective, I'm probably biased, but I think GPs tend to be fairly judicious with our use of investigations potentially. So hopefully that's the case. Second part from Bernard Conway is the amber signs on the pathway seem to ask for referral to neurology if a secondary cause is suspected with no localizing or increased intracranial pressure features. Our CT head guidance from GP requires minimum 3-month symptoms. Is it therefore reasonable to lower this duration threshold to avoid urgent referral to neurology for imaging query space occupying lesion?
I think that's well, if you think the patient's got a space occupying lesion, actually you should just refer them in, and they should be seen acutely rather than an urgent waiting time, which for us is months rather than days or weeks. So if you seriously think there's a secondary cause, the guidance is that we should just be seeing those patients and taking them on. The 3 months, I suppose, is to avoid being overly swamped by stuff and to avoid the clear red flags. I suppose that's pragmatic. If it was straightforward, you would probably just scan the people you want to scan. But if you're scanning for low pressure, CT is the wrong scan anyway. So I think if you seriously think there's a secondary cause, you want to refer them in acutely rather than into a clinic, rather than a CT scan. And really, CT scan of open access is more about the reassurance rather than anything else.
Brilliant. That's really helpful. Thank you. We've got a question around magnesium supplements from Jennifer Gibson. Is there any evidence of magnesium supplements? I saw it mentioned on slide 40. I must confess that was one that was new to me as well.
So there's some evidence of magnesium. The quality of evidence for most preventative treatments is poor, and that includes things like amitriptyline and currently candesartan. The reason it's in there for pregnancy is it's one of the treatments that's safe in pregnancy. So a treatment with some evidence that's softer but safe in pregnancy and a potential to use it. That's why it's in that slide.
That's really helpful. Thank you. I think we've got a $1 million question from George Gorry here, which is very good. How will you know if this national headache pathway is being used and has been useful to primary care? That's a very good question.
Yeah. Stephanie would like us to answer that question as well, wouldn't you, Stephanie McInerney? I think it is important to know how these pathways work and whether they're helpful. I think the question is how to manage it, because if you're doing it from local services, then it takes time, it takes work, and we know we don't really have time to do this. There are some potential national strategies. We're looking in Grampian at doing an AI search on a number of preventative treatments used in track care, so that might be possible. We're looking in Grampian at triptan use and other medication use. I suppose we can do surveys of general practice. I think my view on how to publicize this is attrition. So I've basically taken to putting this in all of my letters and recommending in all of my letters and all of my correspondence. And I think that's probably the best way to get it out into primary care. As a primary care person, do you have a way of of how we should audit this.
So I think that's why I said it was the $1 million question. I think I guess that's probably one of the reasons behind these sessions, isn't it? That the CFSD team are trying to find innovative ways or other ways to make sure we're kind of getting to primary care colleagues across Scotland, both in kind of live webinars, but also ability for people to watch it back afterwards. So, I think that's kind of one of many. I think we know it's quite difficult to get that information out there at all. I guess the point that Anne Wales would be talking about later around the right decision services, I think when that becomes the de facto place for GPs to go, and there's sufficient information on there across every health board, which we know each health board is kind of gradually building up their portfolio of guidelines on the right decision service, then I think it will become sort of the routine place for people to look in the same way as I guess when I'm in practice, I'll use clinical knowledge summaries very, very frequently and other kind of primary care focused evidence-based guidelines, to assist in cases that you're seeing and you think, I just need to make sure I've got this management right or had anything changed. So I think that's kind of the way to get it out there and being used regularly. How we monitor that, I guess we will be able to look at the number of downloads or views or hits on the RDS website, which I think will be perhaps one way to look at it. I think that the good thing about this pathway is it isn't sort of saying anything about, GPs must do X, Y, or Z and making any kind of value judgments about referrals. It's actually about supporting us in something that very much we see, very much is kind of bread and butter primary care in terms of what we see, and providing a restatement of best practice, I guess, which is really helpful and new treatments. That probably doesn't answer the question, George Gorry. I'm sorry, we may have fudged it slightly, but that's my best effort, I'm afraid. I'll stop talking and go back to Callum. We've got, should we be counselling patients about the significant exposure to radiation involved in a CT scan compared to an X-ray?
Yes.
That's a nice easy one. Okay, we've got another one from Nafisa Naz. Is there a specific protocol to follow for the pregnancy prevention program?
So I think that needs to be worked out in each individual locality. But so the MHRA have indicated which pregnancy prevention measures are suitable for topiramate. And in essence, we just need to see the patient, decide whether topiramate remains the right treatment for them, whether they're willing to be on a pregnancy prevention program, whether there is a reason they're not going to get pregnant and therefore we don't need to worry about it anymore. If they're over 55, then clearly we don't necessarily need to worry about it. The question for topiramate is difficult because it's been prescribed in primary care as well as in secondary care. So valproate has been generally a secondary care prescribed medication, and so sits much more easily in a neurology service, whereas topiramate has been prescribed from primary care. And if we refer all these people back to secondary care, then we swamp secondary care, and that doesn't work. I think it's relatively straightforward. You guys know how to prescribe pregnancy prevention, and we just need to ensure that people on topiramate are appropriately counselled, are on an appropriate treatment, and that topiramate remains the right treatment for them. In Grampian, we're currently working with our LMC to produce a protocol in order of what to do so that everybody hopefully has confidence to do it, because the confidence obviously is going to vary between general practitioner to general practitioner as it is from neurologist to neurologist. Hopefully that took that to a fudging answer, but I think it's a very prickly question, isn't it? And it's an important thing to be doing.
Yeah, and I think there's certainly information on kind of the MHRA website which outlines the sort of specific topiramate kind of related questions that you would be looking to ask of the woman who might be taking that medication. I think probably, as you said, Callum, it's about local health boards will need to, through their governance structures, be kind of sharing this with primary care and saying, here is our recommendation. I know from a GGC perspective, similarly, I think that is being worked through currently through kind of prescribing governance colleagues to make sure there's really clear guidance for GPs in terms of what we should be doing, because I think as you say, it is different to Valpro, which wouldn't usually be started in primary care.
Yeah, and I think Topiramate, to be honest, now for new patients is probably a secondary care drug now, because it's going to be a very niche group of people. You know, people with intracranial hypertension, people who have got cluster headache, people who've got, you know, prolonged aura and other things. It's going to be a more logical treatment, whereas a standard migraine prevention, I think it's going to fall away in all of our practice. It's certainly doing that in the headache field.
So hopefully it will become a historic sort of issue, as you say. It sounds like going forward, Callum. Okay, I don't see any other questions. Anyone else would like to ask anything, they can put a hand up, or welcome to submit a Q&A. I think, Jev, I'm right in thinking that people can also submit questions afterwards or comments, so that will come on the feedback form. So I'm sure we can respond to those if needs be. But otherwise, it's just to say thank you very much, Callum. That was fantastic. And we'll look forward to colleagues accessing and using that resource. I will take us on without any further ado to our next speaker, who is Anne Wales, and Anne is Programme Lead for Knowledge and Decision Support at HIS, and is leading on the Right Decision Service tool nationally, which is what we're going to hear about. So over to you, Anne.
Yes, thank you very much indeed, Stuart. And it was great to hear Callum referencing the Right Decision Service toolkit for neurology and the headache section so frequently throughout your presentation. Thank you very much. I think you've covered quite a bit of what I was going to say, but lovely to see it embedded in that way. I've just popped into the chat a link to the web version of the headache pathway on the Right Decision Service, and also a direct link, a direct URL and QR code to download the mobile version of the neurology app. And I'm just going to share my screen now and take you through sorry, I didn't mean to let you see my email there. Take you through a quick introduction to the national pathways from the Centre for Sustainable Delivery and how you can access them at point of care to help in making your clinical decisions in day-to-day practice. And I'll have a specific focus, of course, on the headache content within the Right Decision Service. So the Right Decision Service itself is a tool to help bridge the well-known implementation gap between evidence and practice. I'm sure some of you will be familiar with these figures, that it can take 17 years for validated research to reach routine practice. There's a report indicating that only 18% of practitioners and managers report using evidence-based practice frequently, and a kind of parallel study indicating that only 14% of relevant research actually reaches a patient. So clearly there is this big gap between what's known and what is actually done in day-to-day practice and decision-making. There is good evidence that many types of decision support tool can be very effective in bridging that gap and accelerating the translation of evidence into practice. And it's because of the strength of that evidence and the need to support realistic medicine, reduce variation, harm and waste in practice, that government is now supporting delivery of this national decision support platform. What it does is essentially provide digital tools that bring the evidence right to the hands of healthcare staff and citizens through everyday technology. often through web and mobile apps, as you can see on the right-hand side here, and also through embedding in electronic care record systems. Just to reinforce the government and policy level support for having a national decision support platform, the National Digital Strategy for Health and Care and Delivery Plan and the Data Strategy for Health and Care in Scotland both commit to delivering this National Decision Support Service, and it's referenced frequently throughout the Action Plan for Value-Based Health and Care. So it has quite a central position in government policy just now. The delivery channels for this decision support, just to expand a bit more on those channels. So we have the web-based and downloadable mobile app access through to the Right Decision service. And we also have a number of tools that can be accessed through electronic health and care record systems. The beauty of the Right Decision service is that all of these tools are accessed through a Once for Scotland gateway, and that you can either use the web gateway, which you see on the top of the image on the right-hand side here, or the downloadable mobile app gateway. Both of them will take you to the full range of Right Decision service decision support tools. Here's the links, the link to the website and also the downloadable mobile app. That's how to download from both the Google Play and the Apple App Stores. Any issues, please just contact myself, or if you would like just to find out more generally. What's probably less well known at the moment than the web and mobile access to the Right Decision service tools is the capability for linking some of our decision support with patient record systems. So, for example, NHS Tayside and now NHS Lothian, parts of Greater Glasgow and Clyde have implemented our high-risk prescribing decision support linked with Vision and EMIS. This comprises a set of high-risk prescribing alerts based on around 70 very high-risk prescribing indicators in the polypharmacy guidance. When the clinician opens a patient record, you can see in the background here a Vision patient record. The Right Decision service platform scans that patient record to identify any high-risk prescribing issues that are noted in the polypharmacy guidance. If it finds any, it will push out these alerts in a window in the context of the patient record. The clinician can open up any of these alerts to see the recommendations for action. And just to reassure you, these are quite different from your inbuilt Vision and EMIS drug-drug interactions or your script switch alerts. As you can see from the examples here, these are doing rather more complex and patient-specific algorithmic assessments. So, for example, looking at EGFR levels and combining that information with the prescribing information to highlight the potential for clinical risk. So that was just a little glimpse into the different ways that you can access our decision support tools. We have now around 225 decision support toolkits across a range of topics for health and social care. You can also choose to work with the Right Decision service to build your own decision support toolkits that will support priorities within your health board or your health and social care partnership. And you will see that many of the toolkits in the Right Decision Service come from local boards and HSCPs, as well as from national sources, such as the Centre for Sustainable Delivery. This is the reach of the Right Decision Service, so you can see that over the past 2 to 3 years, it has grown very extensively to broad coverage across NHS, social care, the different sectors and disciplines, as well as resources delivered directly by the NHS. We provide access to quite an extensive range of government programme-funded resources, such as the quality prescribing guides for diabetes, respiratory and polypharmacy. These are just some data on our usage levels as calculated from Google Analytics. So this is quite a substantial resource now, widely used and constantly increasing in its awareness and reach. A few examples of what it delivers. So you can see here we have a collection of all the prospectively all the new sign guidelines published in a decision-ready format. So not just your flat HTML pages and PDFs that you'll be used to, but much more chunked up and readily accessible content for use at point of care, rendered as well into more concise and summarised language for busy clinical decision makers. Just to show you an example of one of our toolkits in mobile format, here you can see the mobile version of the Diabetes Type 2 National Prescribing Guidance, also the National Palliative Care Guidance, now delivered through the Right Decision Service. We have a growing array of referral management pathways. Dumfries and Galloway was one of the very first to make their referral management pathways available through the RDS, but we now have many more national and local organisations delivering referral management pathways through the platform. To turn now specifically to the Centre for Sustainable Delivery pathways, you can see here that we have a collection now of resources from the CFSD, and we have several more in the pipeline, including the respiratory pathways, which we're just beginning to develop now. The neurology pathways comprise one of the toolkits that you'll access through this Centre for Sustainable Delivery collection. And on the right, I've just shown how that collection looks in its mobile format. You don't have to go to the collection. You can do a straightforward search for neurology in the title of a toolkit, for example, and go straight to that toolkit. To access the headache pathway, I think Callum already advised you of this. It's housed within the neurology pathways toolkit, which we've now actually just extended the title to indicate its neurology pathways, including headache, so that if you search for headache in the title, you will find it. And you can see over here the headache section. Opening that up gives you access to this set of headings sitting within which you will see the specific content relevant to those headings, and sometimes subheadings and subsections as well. And again, just for comparison, this is how it looks on the mobile app. Here are the details that I put in the chat just at the start of my presentation. So if you didn't pick them up then, you will have them here in the slides. I'm going to just take 2 minutes to go into the live site so that you can actually see how these work in practice. So you can see I've gone to the URL, Right Decisions, Scott, NHS UK /headache. Here are all the individual headings or topics you might be interested in. So if you want to look at the whole pathway, you can open that up. You'll see another set of more specific headings. You can open up any of these, such as the red flags, to quickly access that very specific information. You can also look at the criteria for referral to secondary care, and you can look at the patient lifestyle advice that Callum was highlighting in his presentation. Also, we have here, for example, the medication overuse guidance, which Callum was referencing. And you can see I was having a look at the treatment strategies. That's still open as a section, but you can easily close it. And just finally, the cluster headache guidance that, again, Callum mentioned is sitting in here with all its subsections for easy access, depending on which particular issue you want to explore further or just check further for your decision making. One of the benefits of the Right Decision service is that we have this combination of decision support tools from different organisations all brought together in one place. So you can easily, from within the Right Decision service, by doing a search for migraine, for example, quickly access the SIGN toolkit for pharmacological management of migraine. You can see the red warning here about the MHRA notice and the link through to the some of the detail about that. And you could also, for example, follow up here on the specific SIGN recommendations about medication overuse headache. So I hope that just gives you a little bit more of a feel for what it's like to use the Right Decision service in practice. Here are some of the principles we aim to adhere to make it really quick and easy to get to that key information for clinical decision making. The Once for Scotland single point of access, so you can find the SIGN content, the prescribing information, and the CFSD pathway all in one place. You'll have seen that we'd extracted out just the, or at the top level, the specific recommendations for action from SIGN and highlighted those, for example, to give that conciseness and focus when you access the information. Plenty of white space as much as we can. We could sometimes do better there. Segmenting and organising the information for speed of access. And in many cases, you can drill down from your top level recommendation for action down to more specific underpinning evidence. I mentioned the local board referral toolkits. Again, one of the strengths of the Right Decision service is that you can access the national pathways and guidelines alongside the local pathways and guidelines. In fact, you can do more than that. You can actually embed national pathways and guideline content within your local referral toolkits or your local guideline toolkits. So we now have these 5 boards listed here using the Right Decision service for their local referral pathways. Dumfries and Galloway being probably still the most well developed. Glasgow quite well developed as well, and looking to expand further. And we have 3 boards currently working with us to get their content up there. One of the benefits that's attracted certainly the most recent boards to the Right Decision Service is the fact that they can very easily embed national pathways, such as from the Centre for Sustainable Delivery, right into their local pathway toolkits. So they don't need to duplicate the effort of writing that referral content. And of course, they can augment it and supplement it with a specific local information about local services. Here's some of the benefits of having local referral toolkits on the Right Decision Service. So when the national pathways are updated, that content will also be automatically updated in your local toolkits using the platform with its close interaction with national guidance and pathways, helps with consistency and application of the same level of evidence-based practice across boards. You can make these connections with related resources such as the SIGN guidelines or prescribing guidelines. And this is some data from last year from Dumfries and Galloway doing a survey of clinicians using their local referral toolkit. And you can see, very positive response, genuinely using this to improve and build confidence in their decision making. And they specifically highlighted migraine as one of the areas where the Right Decision Service had helped. So I hope I haven't run over time too much. I'd just like to leave you with these couple of questions, really encourage you to think about how you can make full use of all the CFSD pathways on the Right Decision Service. And please to get in touch if you would like to know more about creating a local toolkit on the RDS. Thank you, Stuart.
Many thanks, Anne. That was a fantastic overview of the RDS service, and hopefully colleagues will be using that going forward. I don't see any questions in the Q&A. If anyone has got any questions, they could put those into either into the Q&A comment box, or feel free to raise your hand if not. Sorry, Callum.
So I think it's a great tool. For the headache pathway, you can scroll along the pages, so there's a next, which makes it easy. My question is about searching, because currently you're searching for the title, aren't you? Because it'd be nice to be able to search within things, like within the CSFD neurology, so that if you typed in headache, you would get straight through rather than having to be in the title. Is that going to be possible in the future, do you think?
It's actually possible just now, but it's interesting that you asked the question, because it's evidently not obvious enough to the users. When you go to the neurology pathways homepage, you can actually search specifically within the neurology pathways toolkit just by using this search box up at the top. So you'll see it actually says that you're now searching the neurology pathways toolkit. You're not the first person that hasn't been fully aware of that. It's because the same search box when you're on the homepage searches the entire Right Decision Service site. So it's not as obvious as we'd like it to be, that when you move into a toolkit, this will just search within that particular toolkit.
Thanks,
so
Anne.
yes, that's something we could improve. But at least now you can do that.
And I think for GP colleagues, as more and more boards come online with their local toolkits and all of their guidelines are on there, I think it will hopefully become the go-to place for kind of GPs and a one-stop shop, as you say. I think we've talked before about how in the past it would be little bits of paper stuck on a corkboard or in your drawer, or kind of saved as a PDF in your Outlook when they've been sent out kind of through primary care mailings. But I think having somewhere where you can go and access everything that is live, accurate and up to date and covers national pathways and kind of local interpretations or implementation of those will be really helpful. Obviously, ideally, it would be great if we had it embedded in the primary care software, be it Vision and I or EMIS. But I think that's kind of a hope for the future, isn't it? Certainly.
Yes, exactly.
Fantastic. Okay, I don't see
More
any.
than
Oh, sorry.
more than a hope, it's an intention for the future. Let's say that.
Yeah, I like that. I think that's the way. Definitely, there's another comment around searching in the chat there. So, you know, I think certainly, is it fair to say, Anne, that you'd be happy to receive any kind of feedback or kind of queries around
very
that?
much
That would be
so. Yes, yes. Thanks. Definitely.
Brilliant. Okay, super. So I'll just go back to the slide, Jev, with the feedback QR code, if that's okay. So if we'd be grateful if we could have your feedback on today's session, that would be fantastic. The feedback form link is there, as well as QR code. And the next webinar will be in March, the 5th of March to be precise, same time. And that'll be covering gastroenterology pathways, dysphagia, reflux, IBS and IBD. So again, promises to be a really useful clinical meeting, and hopefully we'll see many of you there. So I think it just leaves me to thank Anne, to thank Callum, and to thank you all for attending.